Good evening. We have, we are doing ward rounds, and based on the request of the students, we are doing it as an OSCE. OSCE is Objective Structured Clinical Examination. The origin of OSCE has many sort of reasons. One is the main thing is what happens is as the days become more what should we say, uh, the patients are less cooperative in terms of allowing many people examining them, and and the clinical signs, patients come very early to the to medical attention, and many of the clinical signs which were described before have started kind of disappearing. So what happens is you have a paucity of clinical cases in the examination. So to overcome this problem, this objective structured clinical examination was brought in. So here you usually give a either, I think it is most of the time, scenarios that are there in the ward, patients who have come with a certain problem and they have been investigated, and then you go through this in a structured way. First give the clinical presentation, and then the investigations, then the management and treatment plan. So that is how this goes. I think this is a form, definitely a form of examination. What happens is even DNB has adapted it, and Royal College definitely, all the FRCS exams are based on OSCEs to some extent. So I think it is good to know how OSCEs are done. And Sania, you have actually have you masked the answers?
Yes, sir, yes, sir. I've shared
Okay,
only the question PDF with them.
okay, okay, right. Start, Samir, start this one, sharing the screen, start the first one.
Yes, sir.
So,
So
Vinod,
Guru Shantappa sir has joined.
good evening, sir.
Yeah, good evening, Ravishankar. Good evening.
So we are doing OSCEs. So we would be very happy with your input, sir.
Okay, okay.
Vinod, start. A 69-year-old lady presented with intermittent abdominal pain, lower abdomen, with distension, constipation for 3 months. Clinical examination is essentially normal. So, how would you investigate this lady?
Hello, sir. Hello.
Hello.
Sir, clinical examination as it looking normal mostly, but as the age is around 69 years and saying abdominal distension and
Let us
constipation.
just quickly in clinical examinations, what else would you look in abdomen? You have examined the abdomen. What else? General physical examination, what are the things you might want to see?
Sir, I want to check the anemia.
Yeah, pallor. Yes, pallor. Then,
and I'll also check the heart rate, sir, because maybe because of anemia there will be a rise in and lymph nodes. I will check in the cervical lymph nodes and inguinal lymph nodes. I will check, sir.
Okay. Then what? Inguinal.
Just as a routine, sir, because.
Okay. Okay. Then, so abdomen clinically, as has been mentioned, is normal.
Yes,
so you look for anemia, look for jaundice. You have to look for koilonychia, and also evidence of weight loss in the
Yes,
patient. If the patient is looking cachectic, if there is
yes,
pedal edema, and hypoproteinemia,
hyperproteinemia.
and then PR, you want what would you look for in PR?
I'll check for a mass, sir, first, sir.
Mass per rectum. Then what else?
Yes, sir.
What else?
Uh,
Look for evidence of blood, man, either in
yes,
the
sir.
form of fresh blood or melena.
Yes, yes.
Okay, right. What investigations would you do?
So first I will do an ultrasound, sir, and then
No, you have to do routine. You start with routine
Routine
investigations. Yeah,
Yes,
routine
sir, routine
investigations. Yeah,
routine investigations and
complete. Mention them. Complete blood count,
yes, sir,
which are
complete
all
blood
relevant.
blood urea nitrogen, creatine, and
We usually don't check
serum
creatine. We creatinine. Creatine
Yes,
is
sir.
something different. Okay.
yes, electrolytes, and if it required chest X-ray, I'll do one, sir, and then ultrasound abdomen and pelvis. If
LFT, I think it's
Yes, sir.
important to do an LFT also.
Yes, sir.
Okay. And so ultrasound scan.
Yes, sir.
Have you got any ultrasound report, Samir?
No, sir. Only
Okay. I
the
think
CT scan.
ultrasound, I think you should, ultrasound is very, contributes very little in this situation. Of course, it should do it to, give you an idea. You
Yes, sir.
can, what are the ultrasound, what are the things which may, ultrasound may pick up?
Any fluid collections and
Yeah,
any mass
aside,
is present in the hello.
it may pick up masses, yes,
Yes, sir.
right? Then what else?
Mass and fluid collection, sir, and if there is any liver hypodense lesions and
Correct. Density hypoechoic lesions.
hypoechoic,
not
sorry.
density.
Yes.
Yeah. So presence of ascites, presence of a mass, lymph node enlargement, and liver presence of cholelithiasis may be there. It may show up, and liver mets, hypoechoic lesions suggestive of metastasis. So these are the things which the ultrasound will pick up, and then we'll go for the more definitive investigation. Which is the most definitive investigation here?
Colonoscopy, sir, and CECT.
Yeah, I think I would agree with both colonoscopy and CECT. Okay. Samir, put up the.
Yes, sir.
Read this CT, Vinod.
Sir, this is the transfer section view, sir, at the level of around L2 or L3, sir. There is a bowel wall edema, sir, in the just below the liver, which is
See, there is
and
nothing called transverse section on CT. What do you call them? There are three views. What are they?
so one is sagittal view, one is coronal view, and
Axial view.
axial view. Yes.
So these are the three views. So what is this?
This is axial views.
Okay. What are you seeing here?
This is a plain CT, sir. There is a calcification of aorta and also small.
No, this is not plain CT. There is contrast here. There is contrast there, no? See this.
There is no contrast.
In the bowel, there is contrast, no Vinod.
Contrast.
Oh, okay. In the bowel, it is there, sir. IV
Yeah.
contrast is not. Yes, sir.
You should not make mistakes like this.
Yes, sir. Yes.
Okay.
And there is bowel wall edema, sir, which is on the right side.
More than edema, what is that?
Intersusception, sir.
That is classical intersusception. No, you can see
Yes.
the concavity, convexity inside the lumen of the bowel,
Yes, sir.
and of course it is thickened because of the edema.
Yes.
So, and then as you said, calcification of the aorta, and then there are lymph nodes also.
Lymph nodes, yes, sir. Yes.
So, what is the likely cause for intersusception? It's I think it is cecal I think cecum, intersuscepting into the colon, into the ascending and transverse colon. So it is in the right upper quadrant.
Yes,
Okay.
sir.
So what is the most likely cause for intersusception
Sir,
at this age?
malignancy, sir.
Malignancy or
Polyps.
correct polyp.
Yes.
So you can have either benign polyp, reasonably large benign polyp, or a malignancy, which is the most likely cause for intersusception. So what is, you said colonoscopy. So is colonoscopy required now, having seen the CT?
No, sir.
Huh?
To know the synchronous and these things, we have to do the.
No, not just that.
Yes. And also.
Is it required or not? First answer. See, when I ask you a question, you should just answer the question. Is
Yes,
this is colonoscopy required or not?
No, sir.
Anybody else wants to disagree with him? Nikita, Praveen.
Sir, we have to check other parts of the bowel, sir.
Not just that, man. What is the primary reason why you are doing colonoscopy?
The mnemonic reduction we can try, but it's usually done in only children, no, sir.
I'm not bothered about reduction, but what am I bothered about? Give me the most basic answer, man. See, first of all, we said the most possible probable cause for this is a tumor. Don't you want to see it?
Yes.
So, first of all, go with the colonoscope. You may be able to reduce it, but more importantly, you will know what is the cause for the intersusception. And then, if it is a tumor, you will get histology. So reduction is by the by. If it happens, well and good. Otherwise, you are going to take the patient for surgery anyway. So
Sir,
you want.
sorry, sir, but what about perforation chances, sir? Because it is an old age.
Why should 69 is not that old? Anyway, above 70, I agree with the fact that you have to be careful, of course. So whenever in emergency, whenever you are doing colonoscopy, you have to be extremely careful.
Yes.
If you can't progress, don't try to progress. But
Okay,
you should attempt it definitely in this case, because you want to know the diagnosis and you want to get a histologic proof. But this is
yes.
an emergency because the patient has come with intersusception. There is obstruction. Potentially the bowel is going to go for ischemia, so you are going to operate. So on
Yes,
that count, you can say, I will not want a colonoscopy. So it is important for you to justify your answer.
yes.
If the patient is stable, if there is no, because when clinical examination was essentially normal, it was not as if the patient was distended and tachycardic and there was toxicity. Obviously, in that situation, you are not going to do a colonoscopy. But if the patient is stable, and you may want to consider doing a colonoscopy for the reasons. One, the second reasons that you said, because synchronous and this one other lesions in the colon, yes, that is important. But more importantly, you want to find the cause for the intersusception. Is it a polyp or is it malignancy? Because many times, if it is a polyp, you may not need to do a resection. You may just reduce the intersusception and remove the polyp, and that should suffice. So for that reason, you would want to do a colonoscopy. And if the colonoscopy shows a tumor, then obviously you get histology by taking biopsy from the tumor. And I think the what Nikita said is right, that either colonoscopic or ultrasound, or even in the olden days, hydrostatic reduction of intersusception, generally practiced in kids, not so common in adults, but no harm in attempting it once. And if you can reduce it, fine. If you can't reduce it, then you will anyway take the patient for surgery. But if the patient is, if there are evidence, if the abdomen is distended, if there is evidence that patient is not very stable, then you don't attempt colonoscopy. That is also true. Okay, so what is the treatment in this patient? I'll ask Praveen. What would you do, Praveen?
Sir, right hemicolectomy, sir, and anastomosis.
What if it is a polyp and you have reduced the intersusception?
We'll be doing that or segmental dissection and anastomosis, sir.
Why? So your answer should
Because
be depends on the pathology. The treatment of the patient depends on the pathology. So if the patient has a polyp, which is the apex or the lead for the intersusception, and you try and reduce the intersusception and do a polypectomy, that is a treatment. You don't have to do any resection. If it is a tumor, obviously, then you have to consider doing a resection. Here, what resection will you do, Vinod?
Hemicolectomy, sir, right hemicolectomy.
Is
Because of
that
malignancy.
sufficient? Is that sufficient? The intersusception is coming up to hepatic flexure. Definitely
Extended, sir.
ascending. You will have to consider doing an extended right hemicolectomy.
Yes, sir. Sir, one more question, sir. Sorry. This anyway ascending colon will be attached. No, sir. What is the reason for intersusception? Because
No, cecum is relatively free, right? So
okay.
cecum is the apex of the intersusception.
Okay.
Okay, right.
Yes.
Guru Shantappa sir, your questions before we move on to the next case.
Ravishankar, few points I want a little differ with the discussion. Shall I? Just
Yes,
if
sir.
you don't
Yes,
mind.
sir. Yeah.
Yeah. First thing, when the question was asked, what is the clinical examination you will do? I hope postgraduates are hearing this.
Yes, sir.
Okay.
Yes, sir.
Other than pallor, the first thing where clinical examination of the abdomen was nothing. So in a old lady like this, for rectal examination, somebody said mass. It is not the mass. You will be doing a rectal examination for the growth. Your
Yes.
word mass should be only when you have examined and you have determined that there is a pelvic mass. Then yes, rectally you will be able to appreciate the mass. Otherwise,
Yes,
your
sir.
answer should be growth. You are palpating for the growth because nothing is felt in the abdomen. Old lady, you are suspecting something concerned with a large bowel, maybe rectal growth. Okay, that is one.
Yes.
Second, inguinal notes are not accepted when you are talking about abdominal diseases.
That's what I was.
Unless you want to substantiate that it is a generalized lymphadenopathy and lymphoma is the diagnosis. Okay,
So
don't bring inguinal
I
notes.
failed him. I asked him once. He didn't take my clue. So I said, okay, leave it.
And third, please remember, whenever we talk about intersusception, invariably it is a benign disease at ileocecal junction in the form of either a submucous lipoma or a polyp at IC junction. The malignancies are unlikely to cause intersusception because they will have a submucosal spread and they will have an infiltration. When the bowel wall gets infiltrated by the disease, intersusception becomes less likely. So the presence of intersusception ileocecal in the form of a large bowel disease, likely that it is a more of a benign disease, less likely to be a malignant disease. It can happen in some instances, but more likely it is a benign disease. Okay, so keep a possibility of a benign disease in the form of either a submucous polyp or lipoma or a polyp. And third, the question what you asked, ascending colon is a retroperitoneal structure, how it can have an intersusception. It is not the colocolic intersusception which results in such instances. It is a ileocolic intersusception. It is the ileum which goes inside more into the colon than colon going into the colon.
Yes, sir.
You understood? So it is
Yes,
a
sir.
ileocolic intersusception. Colonoscopy in an intersusception not very often done because invariably they will have an intestinal suction. Otherwise, it is not for the diagnosis. Like somebody mentioned, it is as a treatment modality in children. In children, colonoscopy can be tried. So these are the few points, and it is not a segmental resection for ileocolic intersusception. It is a limited resection. Limited resection wherein you are going to take with 10 and 15 centimeter of ileum and part of the cecum and ascending colon. That is a territory of ileocolic artery. That is called a limited resection. Okay, if you are suspecting malignancy, then nothing short of either right or extended right hemicolectomy.
Yes.
Yeah, these are the few points I thought of
Yes, sir.
mentioning to the
Yes.
postgraduate, Ravishankar. Yeah.
Yes, sir. Thank you, sir. Next,
Okay.
next,
Okay, thank you.
next scenario. I think who will take this? Nikita, will you take this?
Yes, sir.
Okay, so 62-year-old male underwent diagnostic thoracoscopy for a fusion patient with symptoms of dyspnea, cough, fever, or wheeze. Okay, show the picture now. Okay, describe the thoracoscopic findings.
So there appears to be white patchy lesions over the lung
It's
tissue.
not lesion, man. What is this? It's not lesion. Can't call that lesion. There is pleural
White
effusion,
patches.
right? There is
Yes, sir.
pleural.
Yes.
Yeah, pleural effusion is there. And what else is there?
Redness, sir. Hyperemia of the lung is there, sir.
Hyperemia is there, okay. But what is very obvious, man? Why are you going around beating around the bush? You can
White
see
patches.
they are not white patches. What are they? Vinod, would you like to take this question?
Nikita, if same findings are seen in the abdomen or peritonitis, if you have opened, what do you call them? Are you able to hear me?
Nikita, what have you gone blank?
No, sir.
Praveen,
No,
Like
would you like to take this question? What do you see? Describe the findings of thoracoscopy.
It's plaques, white plaques.
Would you call them plaques, or what are they called? Vinod?
Plaques.
Huh?
Plaques.
Nitya?
Sir, deposits over the pleural surface.
You can call these, I think, Vinod, so Samir, point this out here. With your arm. So on the pleural surface, what are they? And then you can see it's very beautifully seen. Where is Tanya?
Sir. Deposits, isn't it a metastatic deposits or a
How do you know it is
tubercular?
metastatic? No, what are you seeing? You first describe, then let us come to the diagnosis. Describe it. Hyperemia, she said, I agree. The pleura and the pulmonary surface is covered by fibrinous exudate.
X-rate.
Purulent fibrinous exudate. And yeah, there are some plaques. I think these are plaques. But majority of it is pleural effusion. There is fibrinous exudate covering both the lung and the pleural surface. So what is the diagnosis? Nikita, what is the diagnosis?
sir, my differentials would be tuberculosis, sir,
Okay, tuberculosis.
and malignant lesions of lung, like probably uh, mesothelioma, sir,
Okay, mesothelioma.
and secondaries of some other malignancy, sir, metastatic.
Secondaries, will they appear like this? Less likely. You would have
Less
more
likely.
of hemorrhagic effusion rather than this kind of effusion. So
Yes.
even suppurative lung disease also can present like this. Significant the purulent pleural effusion, pyothorax or whatever you call it. So one of the, it will be infective acute empyema thoracis, tuberculosis and mesothelioma. These are the differential diagnoses. So what would you do, Praveen, to confirm the diagnosis?
Sir, we'll send the pleural fluid analysis, sir.
Yeah, take the pleural fluid for analysis. Yeah, then
Along with the pleural biopsy, sir.
correct. You can take a plaque for biopsy. And the fibrinous exudate also, take it for what are the things you are going to look for in the exudate.
Sir, for proteins and total count level.
Okay,
leukocyte
all
level,
that. Yeah.
and ADA level, LDH levels, and malignant cells.
Correct. And then
Culture and sensitivity.
correct, culture sensitivity.
Gene experts.
Gene expert, TB PCR. Okay.
Yes, sir. Yes,
And
sir.
then the plaque you can send for histology.
Yes, sir.
Okay. Any questions on this? I thought this was a simple slide. All of you are struggling. Purushanta Prasad?
Yeah, description I expected. See, it's a thoracoscopy finding, no? Here, lung tissue is not seen. First, we are expecting a lung tissue when you put a scope in the chest. Lung tissue is not seen. It's a collapsed lung covered by the plaques. And even on the rib side, the visceral pleura is not seen. These are the findings you should describe first. And there are adhesions, flimsy adhesions between the chest wall and the surface of the lung. So all these findings indicates probably it is a benign disease or inflammatory disease. And don't describe secondary deposits in a thoracoscopy finding, because we don't do thoracoscopy for secondary to diagnose secondary deposits, and it's a imaging, okay, for secondaries. So this is how you need to describe this. So probably it is inflammatory. Is it acute or chronic? That you have to describe. Looking at the flakes and these flimsy adhesions may be acute inflammatory disease.
Correct.
Yes, this is how it should go, neutrally, without taking any specific disease. Okay, thank you.
Thank you, sir. Next slide. Okay. Ainas, would you like to take this question?
Yes, sir.
You've just done 58-year-old gentleman presented with history of painful lesion in the tongue. Okay, show the picture,
Yes,
man. Describe the lesion. Where is it and what is it?
There's an erythematous lesion which is present over the lateral aspect of the tongue, sir. Yes, sir, and it is associated with kind of irregular margins as well, sir. And yes, sir, but no active bleeding noted at as of now, sir, like in the picture.
Why is that so important to say that there is no bleeding?
So for traumatic causes, sir, just to rule out traumatic causes, we could consider bleeding as well,
does
sir.
it look like a traumatic thing to you?
No, sir.
Then why are you unnecessarily digging?
Okay.
Just describe what is there.
Yes, just like a erythematous irregular lesion over the lateral aspect of the tongue, sir.
Describe the whole thing. Rolled up edges are there. The length and breadth of the swelling. What is the base of the lesion look like? Is it extending beyond its its territory? All these things you should describe, no?
Yes, sir.
Okay.
Like, yes.
You want to describe this?
Irregular lesion of around 1 into 2 centimeters present on the lateral aspect, sir, with everted edges.
Okay. Keep
Yes, sir.
going. Don't stop.
And it looks the floor looks like granulated tissue, sir. There is no necrotic material or anything. So and history is around 2 months, so it should be diagnosed for further. It requires further investigations.
What are the points in history you would like to elicit?
Durations are one, and it is how fastly it is changing, and the pain
Okay,
is started recently, or
how did it start? Then what is the rate of progress? Then what else?
and about history, sir, personal history of this tobacco, alcohol, and cigarette smoking. And any history of bleeding, sir, from the lesion. And how it is progressing, and what about his feeding while eating, any difficulty in eating, and voice changeovers?
No, voice change may not happen, but what else can happen? Why will the voice change? Voice won't change, but something else can change.
Christmas.
Not trismus. Where is the tree for tongue? Why are you getting trismus, man?
Extension.
No, but you can see the extent, no?
Yes, sir.
There can be, his speech may be altered.
Yes, sir.
Because the tongue it's painful lesion on the tongue. So he may
Yes,
not be able to speak well. But why will there be no change in voice as such?
Okay.
What investigation would you like to do?
Biopsy, sir.
How will you do the biopsy?
Wedge biopsy from the edge of the tumors.
Under local or general?
Under general.
Where will you do the biopsy? In the treatment room?
In the treatment room only we can do it, sir. But if the patient is not supportive, we have to do it. And
patient is not supportive. Why will the patient support you, man? Patient is not cooperative. No, but I think more importantly, what are you worried about when you are doing biopsy in this region?
Bleedings.
Can have significant bleeding, and
Bleeding,
that
yes.
blood, if it swallows, then it will be a problem if
Yes.
it continues to bleed. So better to do biopsy in the OT so that you can control the bleeding when you finish. And
Yes.
you can give, it's difficult to give local to the tongue, but maybe you can try if the patient is cooperative. Otherwise, you can do it under sedation or general anesthesia. Okay, so you can get, where will you take the biopsy from?
From the edge of the lesions.
Rolled up edges, including
Yes,
the
normal area.
Yeah, take wedge of the tissue, including normal
Yes.
area. Okay. What apart from the biopsy? What else would you do?
If I want to further, I can do ultrasound next, sir, for any lymph nodes and anything.
Okay. And then what else?
And highly suspicious, we can do CT head and neck, sir.
When will you do CT scan? When will you do ultrasound scan? You're not answering the question correctly.
Yes. Sir, if it is infiltrative close to the mandible, then we'll highly prefer the CT, sir. Otherwise, ultrasound or MRI is enough.
or MRI. You are digging, think slowly but surely.
Yes.
Ultrasound scan is sufficient to look at the lymph nodes.
Yes, sir.
You want to look at the lymph nodes and see if the lymph nodes are enlarged, and then characterize the lymph nodes by the ultrasound to see whether it is just reactive lymphadenitis or secondaries from the lesion.
Yes, sir.
If there is infiltration along the floor of the mouth, or as you said, if there is involvement of the mandible potentially, then CT scan will
CT.
be required, because CT will give you good bony definition,
Yes, sir.
and it may also give you to plan the treatment, a roadmap to plan the treatment. So how would you manage this if at all it turns out to be a malignancy?
Sir, as a lesion, if it comes under close to 2 centimeters, hemiglossectomy I'll advise if it is malignancy.
It is I told you it is malignancy. So
Yes, sir. Yes.
hemiglossectomy, what else? And then?
And flaps, right forearm flap.
To cover the tongue, you mean?
Yes. Yes, sir.
Why do you want, if you are doing a hemiglossectomy, why do you want to cover it?
Voice and
Will it not heal on its own?
so, but the tongue won't be sufficient. How hemiglossectomy we are doing? So for the speech and mastication, it is.
So you are going to use a
radial forearm flap.
You want the radius bone as well?
No, sir. Only fasciocutaneous flap.
Okay. And what else will you do?
And it is greater than 2 centimeters supraomoid neck dissection is required, sir.
For this one, I think you have to do a
supraomoid neck dissection, and as it is specifically tongue, extended supraomoid neck dissection is.
You have to do a neck dissection, definitely.
Yes, sir.
It is now mandatory to do a neck dissection. What neck dissection will you do?
Extended supraomoid neck dissection.
What is extended supraomoid?
Level 1, 2, 3, 4 will be removed.
What are the lymph nodes that drain the tongue and the floor of the mouth?
Sir, floor of the mouth will be 1 and 2, sir, on the either side, and if it is in the center, in apex and in the center, and tongue in the tip, it will be 1A, in the lateral ends will be 1B, and base will be deeper and into the 1B and 2, sir, and there will be chance of skip meds directly into the 4.
Okay, so you have to remove, what are the nodes you are going to remove?
1A, 1B, 2, 3, 4, sir.
Okay. Purushanta Prasad?
In this case is with N0 neck, what you have presented in the information?
Yes, sir, N0.
N0.
Yes, sir.
Okay. In the discussion, MRI tongue was not mentioned, if I have heard correctly. Was it mentioned?
Mentioned, sir.
Okay. What is the view you take in MRI tongue?
Sorry, sir.
You didn't understand the question, or you don't know the answer?
No, I don't know. View, I don't.
Okay. MRI tongue, you should use the puffed cheek view. So that all the structures will go away, only tongue will be in the center, and they will be able to visual, because it's a soft tissue.
Yes,
so
sir.
it is a puffed cheek view for MRI tongue, for any tongue lesions. One of the ideal investigation which will tell us what is the depth of involvement. Depending on that, because AJCC 8 classification, it is not only the histology, even the depth is included.
Depth is, yes.
Yeah, depth is included that you can make out on imaging. So MRI tongue is a must for tongue lesions. One. And second, for N0 neck, extended suprahomide is not required because clinically it is N0. So you have to do only suprahomide. Depending on the histopathology, you should decide further neck management. Okay. So what we expect for the postgraduate when you have such a case, you should describe treatment of the primary and addressing the neck. That is treatment of secondaries in the neck. Okay. That is how you should be able to describe. And for hemiglossectomy, a free flap of the fasciocutaneous, what you mentioned, is acceptable, but there are many other better options. Like either you can use the
PMMC.
either you can PMMC also will, you see, whatever these flaps, they will restrict the mobility of the tongue ultimately. Nowadays, the trend is you should have the physiological tongue rather than the anatomical tongue. After doing the like either wedge resection or only tip resection or hemiglossectomy. So if it is a hemiglossectomy, even if you rotate and do a reconstruction, it will restrict. The tongue size becomes small. So earlier people used to do this, but nowadays it is not advocated because we need to have a physiological tongue. Like movement should be there. Okay. So just putting a graft at the resected tongue area also is acceptable. Or if only part of the tongue is there on the hemiglossectomy side, you can use a mucosal flaps, then the free flaps. Okay.
Okay.
So in a SOH specimen, you have to find out what is the number of nodes. Is there any perinodal spread, lymphovascular invasion, and a perineural spread? These are the 4 factors histology which will decide what is to be done next.
Yes, sir.
Okay. So with a nodes positivity. That is a different discussion only. That is a different discussion. So this is exact. It is like mathematics. If you read Devita and prepare notes, you will understand so beautifully. It is like mathematics. So just prepare and simple discussion. Okay.
So, that is why I told you, why are you doing MR? I wanted you to answer this question
Depth
that
of
way.
invasion. Yes.
So basically, soft tissue MR, bony structures CT. Okay, so that is what you should know. Okay, next slide, please. Okay, now whom shall I ask this? Praveen, patient comes with acute appendicitis. Confirmed. How are you going to take the consent for appendicectomy?
Sir, first what procedure will be doing and
No. You tell me
Yes, sir.
everything. Don't soon. You have to tell me. If I am the patient, you tell me what are you going to do. Carry on.
Hello? Yes, sir. Based on the recent one, we'll be doing the laparoscopic appendicectomy.
No. I am telling
Yes, sir.
you. I am the patient. You are going to tell me what are you going to do. So take the consent from me.
As we have confirmed diagnosis of appendicitis, the treatment will be of appendicectomy. This is of 2 procedures, open and laparoscopic method. Laparoscopic method is a recent and well-versed method. So we'll be doing through laparoscopic method, which is a keyhole procedure involving only 3 ports, one 1 centimeter and 2 5 mm ports. And through the laparoscopic ports, we'll be operating and we'll be doing the appendicectomy specimen. But there is a chance of other complications like mass formation and involvement of bowel. So in such conditions, if we cannot proceed with the laparoscopic, there might be chance of converting to open. So there is chance of both. We'll be doing the lap, but there will be chance of converting to open also. And if there is involvement of bowel, so there might be chance of resection and anastomosis of bowel. And
Carry on.
yes, sir. And if there is pus collection, there might be necessary for placing a drain in the abdomen, which will be removed in the later date once it comes down. And
Nikita, do you want to improve on that?
Yes, sir. I would like to start with saying that there are two options to proceed if you have appendicitis. The definitive
There is no
management would
question
be
of
appendicitis.
if you. There is no question. You have now confirmed the diagnosis of acute appendicitis. So proceed from there on. See
Yes,
the
sir.
question.
Now that you have appendicitis, there are two ways for the management. One is a conservative management, the other is a surgical management. Surgical management would be the definitive management, like without any recurrences and no further problem in a general point. But if you're not immediately ready for the surgery, we can go for antibiotics. It will settle for the next few days, but there's a high chance of recurrence in the next few months. Once if you're attacked with appendicitis, it keeps on recurring. So I would recommend you go for a laparoscopic, surgical management. Then in the surgical management, how we can do is again two ways. One is an open surgery, and the other one is laparoscopic surgery. We are equipped with the laparoscopic machine, and we are routinely doing laparoscopic surgeries. So we'll be performing laparoscopic surgery to you. But in case if there is any difficulty because of the severity of the appendicitis, then it might get converted to open. There is a very less chance, but we have to inform you in case it gets converted to open. And if we do not proceed with the surgery, and if we continue to have appendicitis, there is a high chance of complications, which would be severity of the infection to the surrounding tissues, and also chance of perforation that will lead to the complete sepsis and you going to an ICU. In that scenario, the surgery will also be difficult. The recovery chances are also very different from the current situation. And the basics of the procedure I'll explain, sir. Like
First of
imagine
all,
that this room is your. Yeah.
none of you told anything about what anesthesia you are going to use. So patient needs to know, right?
Is in
So
basic
don't you see?
procedure of the surgery. I'll explain. Yes.
Have you seen me, counsel the patients?
Yes, sir.
yes, sir.
What do you do? First thing, you have to
We'll
talk
tell
to
them that.
people. You have to talk to
Yes.
people in their own language. Take their hand, show them a vein. Usually, have you not seen me do that? Show them the vein and say, we'll put a plastic cannula into the vein and we'll give you anesthesia. You will be completely asleep. Is that not clear?
Yes, sir.
Yes, sir. Yes, sir.
So first thing, see, you are consenting the patient. So you can't presume that they know anything. You have to presume they don't know anything at all. So you are telling them everything from start from scratch. So we will be doing this procedure under general anesthesia. You will be completely asleep. You will not know anything. So that is that every common man will understand that. So first thing you have to say, as I think Nikita added quite a few things, that conservative management is definitely an option, not used anymore unless patient is not fit for surgery or the patient refuses surgery. Conservative treatment is generally not or the patient has already come late for the procedure. If there is already a mass that is present and patient is relatively stable, then you can admit the patient and give them IV antibiotics and manage them if there is already a mass. But if the CT shows that there is an abscess, then again you can't wait on that. This is how you have to counsel the patient. Depends on the findings on the ultrasound or the CT scan that you have done, and also the general condition of the patient and the total count and all the paraphernalia, which will give you an idea as to how severe the appendicitis is. Is there just acute appendicitis? Is there an abscess? Is there a mass? All of these will help you to make the decision as to how you are going to manage the patient. So this is how you have to counsel the patient, depending on what you feel. And then I think Nikita said about if you don't operate, what will happen? That is also important, because counseling also, consent will also mean, if the operative management is not, when the patient doesn't consent for that, then he has to know what is he letting himself do. So that is also part of the consent process. Then you have to mention the complications. I think some of them Praveen mentioned, which is abscess and drain replacement of drain and all that. So you can subsequently, in the post-operative period, patient can have sepsis, patient can have further fluid collections in the right iliac fossa, in the pelvis. They can have acute intestinal obstruction, wound infection, and then all the other general complications like pneumonia, urinary tract infection, DVT if the patient is not mobile. All of these things will form part of the consent process. So that is how you have to consent the patient. Purshanta Prasad?
Yeah, everything was described pertaining to this case.
Yeah.
Consent. Fine.
So I think the most important thing is that you have to, the consent process is, you have to mention this very clearly, the consent to be taken in the patient's own words, in the language that the patient can understand. If the patient does not understand, you have to repeat whatever you are saying, still the patient is, you can also take the help of a relative to be sitting with you. Sometimes it is not just the language. Even though you are talking Kannada for that patient, the patient may be from North Karnataka and he may not understand some of the words that you are saying. Take the help of the relative and explain to them, and then make sure that the patient understands, he or he understands what you are telling them. So you tell them the diagnosis is acute appendicitis. Generally, we recommend that you undergo surgery, because only 2 or 3% of the patients over the next year will escape appendicectomy. Otherwise, majority of them will have repeated attacks. Don't use the word recurrence. Usually recurrence is usually confined to cancer. So you can use the word recurrent attacks of pain and fever and vomiting, and recurrent attacks of acute appendicitis. I would rather use that rather than saying recurrence. Praveen. So it's not cancer for it to recur. Though you are, essentially right, because it is recurrent attack of pancreatitis, of appendicitis. But generally recurrence is, used to, denote cancer coming back. So that is why you use the word, repeated attacks of acute appendicitis. So you can tell them that, if you don't undergo surgery now, you are likely to have repeated attacks of similar pain with fever and vomiting, and sometimes even leading to complications. So, and other thing is, if the patient has already had a appendicular mass on the CT scan and there is no evidence of appendicular abscess, you can do a conservative treatment, but also warn the patient in that situation, if things do not settle, we may still end up with operating. So all of these things have to be very clearly told to the patient. Any questions or clarifications? Anybody?
No, sir.
So what you can appreciate is, even a very simple acute appendicitis, if you don't answer correctly, you can, the examiner can catch you out in so many areas. Okay. So we'll
Sir,
move to the next.
50 years patient, should we explain about malignancy, sir? Any chance?
50-year-old unlikely, but you can still, it's very unlikely. But again, if on the CT scan there is evidence that there may be some thickening of the bowel or whatever, then you can mention that. Then you can say that we may have to do a limited resection of the bowel also.
Yes, sir.
Okay. Next question. So this we have already covered. Huh?
Yes, sir.
Consent. So you have to tell them the diagnosis. You have to tell them what the diagnosis means. You have to tell them what are the treatment options available. You have to then, describe the procedure that you are going to recommend, but also describe the open procedure, and then the complications, and also what happens if the patient doesn't go through with the operation. So all of this will form the part of the consent process. Okay, next one. Okay, show the picture. Who is going to take this question? Vinod?
Patient will have additionally compressive symptoms, sir, like stridor and dysphagia.
Because I think they have already said euthyroid. Is that why you are saying these things?
Yes, sir. They have asked one other than swelling, what are the symptoms because of euthyroid?
So because it's euthyroid, you may not need to describe the symptoms of hypo or hyperthyroidism.
Yes, sir.
Okay. So what are the things you would expect?
The compressive symptoms are basically because of stridor and dysphagia.
Difficulty in breathing. Okay, stridor. Then?
Difficulty in swallowing, sir, dysphagia.
Okay, and then?
See, the question was looking at that specimen and the X-ray, what is that symptomatology you expect? We are not asking in general about thyroid swelling. Look at that image. They have labeled something. Look at the X-ray. Looking at that, you should tell us the extra symptoms. Just like that, you cannot go on mentioning the symptomatology in a goiter. Look at them. Get a clue from these two.
See the neck X-ray. What is there?
Even a specimen. They have mentioned something. Just see that.
Retrosternal extension and
exactly. That's yes, what probably Ravishankar is expecting with
yes,
that film. Am I right, Ravishankar? Am I right?
And look at the trachea.
Yes, a
Deviated.
deviated.
And deviation. And it is a retrosternal goiter.
You can see the compression also, and also retrosternal extension. So what would you expect during surgery? What trouble would you anticipate during surgery?
Identification of recurrent laryngeal nerves, and also this retrosternal extension, the difficulty in getting out it, sir, and chances of doing sternotomy, there is a chance, and intubation, and there is a after removal of the specimen, there is collapse of trachea is also high chances are there.
What is that called?
Laryngomalacia.
Tracheomalacia. Okay.
Sorry.
But more first, what you said, difficulty in extraction. I agree with that. Recurrent laryngeal nerve. I agree with that. What else can you have?
Vasculature, sir, bleeding.
Correct. Bleeding can happen. Where does the trachea? Where does the thyroid take its blood supply?
Superior thyroid and inferior thyroid, sir.
I'm specifically asking in this situation, man. I know the superior thyroid and inferior thyroid.
Okay. Superior thyroid, sir.
Nitya, where is the blood supply coming from in a retrosternal goiter?
So there can be even a direct branch from the arch of aorta, sir, the thyroidea artery.
That is there normally also, man. What is the answer? You are a registrar. What should you say?
Superior thyroid.
No. See, superior thyroid, inferior thyroid is correct. But what is the answer that we are expecting in the exam? Anybody else? Tanya? See, the answer we are expecting, I'm sure Professor Gurshanta will agree, is that the retrosternal goiters carry the blood supply from the neck. Okay, so you control the blood supply in the neck itself, unless they are true mediastinal goiters, where then they can have the blood supply. For example, the brachiocephalic vein could be stretched over the thyroid as a tape in a true mediastinal goiter. So unless, and then you can have branches from the vessels in the mediastinum also. If it's a true mediastinal goiter, that is where there is no thyroid in the neck, and if there is a goiter in the mediastinum, only then they can have blood vessels from the mediastinum
Right.
itself.
Yes.
Otherwise, majority of them will carry their blood supply from the neck. So, if you control the bleeding from the top, you are generally okay. Purshantapa sir?
Yeah, agreed. What he says is they are called grade 3 retrosternal goiters. Grade 3.
Correct. Grade 3.
Maybe
Yeah.
up to arch or below the arch of the aorta. Grade 3.
Correct.
So they will have
Yeah.
their independent blood supply. Otherwise, majority is from the neck.
Neck. So, what difficulties would you expect after surgery, Vinod?
Uh, Respiratory difficulties and one more recurrent laryngeal nerve with chances of injury. So
Yeah.
respiration. Yes.
Stridor, you can
Stridor.
expect stridor, tracheomalacia, because
Yes,
it's a
sir.
long-standing swelling which is compressing the thyroid, trachea, and once you remove it, you can have. How do you overcome tracheomalacia?
Um, mm, Calcium.
Hmm? And what is the fourth answer to the fourth question? If left untreated, what potential difficulties will the patient face?
Sir, cardiac preload will be decreased and it will be leading to cardiac
Why
failure, sir,
cardiac?
and
Why cardiac?
because of vessel compressions and also facial
Oh,
puffiness and this.
vessel, what vessel will it compress, man? I think you can see the neck, it is compressing the trachea.
Yes,
That's
sir.
all. So you can have stridor. If you don't operate on this patient, you can have stridor, and then mainly it's breathing difficulties. That is that's the main thing that
Okay.
you are talking about. And potential, because it's a multinodular goiter, malignant transformation is another thing you can say.
Yes, sir.
Sir, Purshantapa sir, anything to add, sir?
Yeah, nothing. It's a big topic, but it's all right. They have answered many things pertaining to the X-ray and the specimen.
Yeah, okay. No, this is
What
because
is
it's
lost? What is the lost thyroid? LOST. Yeah, Ravishankar, let them find out. This is the homework for us.
yeah, I think. Correct, sir.
Don't search in the Google. Please find out from the books.
Correct. Okay, so now what is the 10 o'clock? 5 questions, sir. Shall we stop here, sir?
Huh? Pardon?
Shall we stop here? We finished 5 questions.
Yeah. It is enough. It
Yeah.
is enough.
Yeah.
I think they were very good slides and good discussion. Just a single sentence and one picture, and there was a lot of discussion on that.
Yes.
Yeah, it was nice. It was nice.
Thank you very much, sir.
Thank you.
Any questions or comments from Registrar Sania?
Sir, very good scenario, sir. Covered most of the things in each scenario.
Okay. I think that, see, what all of you have to understand is that even very simple things we projected, the questions can be very myriad. You can go from any to any length. So what is important is you have to logically deduce the question answers, and I think, and answer to the point. I think in OSCEs, I think the main thing is objective, structured. So there is a structure to the questions, and there should be a structure to the answer. That's all. Okay. I think we'll do more of this so that you get used to the idea. And this will be both pre-operative and post-operative. So whenever there are certain scenarios which are post-operative, we can discuss post-operative things also. Okay.
Yes.
I think if
Thank
there are
you.
no further questions, we'll stop here. Good night, all of you.
Thank you. Thank you. Thank you.
Thank you
Thank you.
very, very, thank you very much, sir, Professor Gurshantapalli.
Thank you.
Thank you.
Thank you. Thank you.
Good night.